the future of neonatology, the less is better. So the less non-invasive ventilation at morning and SALSA tomorrow, inshallah. We are talking about the inhaled steroid. Okay. So I have no conflict of interest, financial. So Banha, it is Banha, not Benha. Banha in the north of Cairo, like 40 kilo in the north of Cairo. The university started at 1978. So we have Nile Corniche. This is a view of Banha. And Banha is the capital of Qalyubiyya Governorate, where the Nile River divided to two branches, main branches, one in the west and one in the east, Dumyat near Port Said, and the other Rashid near Skandaraya. And this is Al Qanatir, where it's a very famous, as this is the logo of Qalyubiyya. Okay. So respiratory morbidity is the most common cause of admission in an ICU. Either the RDS and the preterm babies or transient tachypnea of the newborn and associated with meconium aspiration.
This is still, we have controversy, management, prevention, and
management.
Bronchopulmonary dysplasia. Corticosteroid is one of the most investigated medicine or drug in neonatal care. More than 90 trials, randomized trials, more than 9,000 newborn studies for the effect of steroids, either systemic or inhaled. And still we have no clear answer. We can use or we cannot. So today we'll discuss how the steroid work in bronchopulmonary dysplasia, discuss the effect of inhaled steroid in management of PPD. This is the main goal. Discuss the update of intratracheal installation of corticosteroid for management of bronchopulmonary dysplasia. Review if there is any role for transit inhaled steroid in TTM and meconium aspiration. We know bronchopulmonary dysplasia, the rising problem because we have with improvement of the neonatal care, we have many premature and microclean baby living. More than 50% of low birth weight infants have bronchopulmonary dysplasia, and still affecting the baby after the neonatal age. And we have many problems, neurodevelopmental problem and bronchopulmonary. We know bronchopulmonary dysplasia is multifactorial pathogen. One of the main causes is the inflammation. So, steroid as anti-inflammatory drugs has major anti-inflammatory drugs used to treat or to manage or to prevent the bronchopulmonary. Both systemic and inhaled, with their anti-inflammatory actions, are often used for bronchopulmonary management. The effect actually through reducing inflammation, reduce lymphocyte count, promoting anti-inflammatory cytokines, suppressing the pro-inflammatory cytokines, accelerating the lung proliferation, and enhance the production of surfactant, decrease vascular permeability, and increase the lung fluid absorption, which is reflected on the lung compliance outcome. So, as we know, the systemic corticosteroid has short-term and long-term problems. The short-term, we have GIT perforation, GIT bleeding. Also, we have hypertension and hyperglycemia. The problem usually comes with a long effect, especially in the neurodevelopment effect and the growth parameters, especially the head circumference. This is why inhaled steroids looks a reasonable alternative to systemic steroids. The specification, it has higher pulmonary deposition, reduced systemic bioavailability, rapid systemic clearance, beneficial effects on the target organs with the reduction of the adverse systemic complication. Did the inhaled steroid meet our expectation or not? We'll see. So I will review the meta-analysis. So we have 3 meta-analyses actually for the inhaled steroids. One of them said it is early use. They review the early use of inhaled steroids. They said earlier than 14 days. The meta-analysis of early inhaled steroid in the study, we have 1,644 terms. The result was reduced bronchopulmonary dysplasia risk among survivors, reduced composite outcome of this bronchopulmonary dysplasia at 36 weeks post-menstrual age, significant reduction of use of systemic steroid, no significant difference were found in the neonatal morbidities and the other effects. Actually, this meta-analysis takes the early and late. This is the whole, and also is going with use of inhaled steroid, increasing the bronchopulmonary dysplasia at 36 weeks. But one of almost half of the babies used in the meta-analysis was coming from one study, the European study for inhaled steroids, neurosis, almost the half. They recruited 813 infants, gestational age between 23 and 27 plus 6 days. Any form who needed any form of positive pressure ventilation, positive support at the first 12 hours of life. Budesonide was given 400 micrograms every 12 hours for the first 14 days, followed by 200 micrograms every 12 hours for day 15, from day 15 until the last dose of the study. The last dose, either the baby no need more oxygen support or the pressure support, or the baby reaches 32 weeks. Budesonide group saw significant reduction in the bronchopulmonary dysplasia, 28 versus 38, reduced composite disk or bronchopulmonary dysplasia at 36 weeks post-menstrual age, 40 versus 46, but we have increased mortality, in almost 17 versus 13.6 at the age of 36. I think there was no planning for follow-up, but for this high mortality, they did follow-up study for like 18 to 22 months for this baby. They found no difference in the neurodevelopment disabilities. We have many studies following the inhaled steroid at 18 to 20 months, but still the mortality continued to be high. It's almost 20 versus 14.5. What about the late inhaled corticosteroids? The meta-analysis discussed the late inhaled corticosteroids, explained after 7 days until complete 36 weeks. This is the last update of the meta-analysis or the Cochrane review site. This is done in 2022. This is update for 2017, done by Professor Onland. They used 7 randomized control study, 218 preterm infants comparing inhaled steroid versus placebo. And at this update, they removed one study which was containing systemic steroid. The updates, the review at 2017, it was 8 studies. But either in this update, 2022 or 2017, they still no effect correlate inhaled corticosteroid in improvement of the incidence or the composite incidence of bronchopulmonary dysplasia or bronchopulmonary and mortality. There is meta-analysis comparing inhaled steroid to systemic steroid. Also either early inhaled and late inhaled. For the early inhaled, there was no clear difference between early inhaled steroid and the early systemic steroid for bronchopulmonary dysplasia, mortality, or cerebral palsy. The difference in other short-term outcome in the Cochrane review include longer duration of assisted ventilation and oxygen therapy for the baby who received inhaled steroid, less hyperglycemia with inhaled steroid. Also, for the rate inhaled corticosteroid in comparison to systemic steroid, there was no evidence for any benefits or harm for inhaled steroids compared with systemic steroids for bronchopulmonary dysplasia, mortality, or cerebral palsy. Other short-term complications of corticosteroid were not substantially different between this group. Even. Right. So what about corticosteroid instillation or intratracheal administration? Looks at alternative to conventional nebulization, instillation of steroids with surfactant into trachea. Surfactant has unique spreading property, enables the mix of this steroid and reach to the first area in the alveoli, maximizing its anti-inflammatory effect and distal gas exchange. Different inhaled steroid studies, budesonide is one of them, and mostly used because it can be conjugated with the fatty acid of surfactant of the cells, lung cells, with gradual release, which prolong the anti-inflammatory effect in plasma concentration 1/8 of lung tissue, short thermal half-life, rapid metabolism in the liver with minimal systemic. So the pilot study done by Ye in Taiwan, Professor Ye, intratracheal administration of surfactant of 100 milligrams of surfactant mixed with budesonide 250 microgram, and the control infant received only surfactant 100 milligram, with significant lower incidence of bronchopulmonary dysplasia in this, decrease the need of exogenous surfactant at second dose, no short-term complication like infection or arteriopathy prematurity, no effect on neuromuscular or cognitive function at the mean of age of 3 years. This is also, they have follow-up study. So, Dr. Ye followed by multi-center studies done in Taiwan and United States, and they yield the same result. And this is a meta-analysis for both studies, which is going with good effect, significant decrease of both bronchopulmonary dysplasia and bronchopulmonary dysplasia and mortality at 36 weeks. However, several recent studies found there is no significant effect between instillation steroids and the control group with surfactant only. Many studies, recent also in 2020 or 2019. One of them is escalation dose. They tried different doses of steroids or budesonide to detect its effect. This is the correct dose or not. They try 25 microgram, 50 microgram, 100 microgram mixed with the surfactant. This study found totally the babies have no significant difference in the rate of bronchopulmonary dysplasia. Even the control is better. But they found most of the affected baby, as you see, this is the first study. The babies who receive the lowest dose, the 10th dose, is effective in prevention. But when they are reviewing the study, they found these babies have little bit larger weight in comparison to the other groups. Also, budesonide surfactant has no clinical respiratory benefits at any dosing level for intubated extreme low gestational age newborn. 1/10 dose of the previous concentration known as minimal systemic metabolic effect and appeared effective in lung-targeted anti-inflammatory action. He said because they did also inflammatory markers either in the aspirate or in the blood of the baby. So this difference in the result, why is the difference? I think it's many explanations. The timing to give the inhaled steroid with a surfactant. The pilot and the multi-center study by Dr. Ye done, they gave surfactant within the first 4 hours. Other studies give when the baby has CPAP failure or need positive pressure not to be intubated, mostly after 12 hours. SESI study which evaluated the doses started from the 3rd day to 14 days. Okay, this may infection also the criteria of admission of the babies. Some use the weight less than 2.5 or 2.25, and some studies use gestational age. Also, maybe the race. Many studies done Taiwan, Korean study, and Western or United States. So we have for effectiveness, this is a meta-analysis in 2022. for the effectiveness and safety of early or combined utilization of budesonide and surfactant by airway for bronchopulmonary dysplasia prevention of preterm babies. In randomized study, 6 presented in English and the other in Chinese, total 1,735 premature infants, RDS 858 budesonide group, and the other is a control group. The result, early combined utilization of budesonide and surfactant in the airway superior in bronchopulmonary incidence, mortality, the composite outcome, bronchopulmonary dysplasia of mortality, additional dose of surfactant, no need for additional surfactant, duration of assisted and invasive ventilation, duration of hospital stay. These benefits were not associated with increased adverse outcome. Conclusion, the early installation of budesonide and surfactant by the airway might be an effective and safe for bronchopulmonary dysplasia prevention in preterm babies with RDS. However, many of the included studies were small, were from Asian origin, more well-designed, randomized control study with larger sample still. And this is what going now. We have many studies or randomized trial working. The one of them is plus trial recruiting almost 1,000 baby. Also PIP trial 1,106 baby, and different sites in Canada, Taiwan, United States, Spain, Australia. I think this is the era. In the next few years, we may have recommendation in the usage of intratracheal installation of steroids. I will this. So, what is the effect of tachycardia? Transient tachypnea of the newborn is one of the most common cause of admission of the late preterm and term babies in the ICU. Actually, we have increasing the number in Egypt because we have very high level of cesarean section in Egypt. The baby liver like 27, 28 years. Most of them have with increasing the risk of transient tachypnea. The pathogenesis is related to the epithelial sodium channel, which is the important pathway for clearance of lung fluid. Lower expression of epithelial sodium channels is possible, one of the possible cause mechanisms for transient tachypnea of the newborn. This is antenatal ELSLAC, and postnatally, normally we should clear this air fluid. However, the steroid may show increase the transcription of epithelial sodium cells, decrease the rate of its degradation, increase the activity of existing channel. This leads to clinical trial. This is why the rationale we may give inhaled steroid in the transient tachypnea. Actually, one study done in Israel, they recruited 49 babies and they found no effect. They gave the baby inhaled steroid, 2 doses, 1,000 microgram, 12 hours apart, and they followed the baby with respiratory parameters and the removal or weaning from oxygen. No detected side effect, but respiratory support at each time, point of time, continuous unsupported breathing. No difference between the two groups. Clinical score, no different. Even respiratory support or discharge, no different. The conclusion, the study was unable to detect the beneficial effect of early administration of inhaled steroid on clinical course of transient tachypnea of the newborn in late preterm and term infants. Larger studies still needed. The study repeated in Egypt for 100 baby, but they used distilled water in the placebo, which is very strange. They found better outcome, and they have evaluation also for only number of babies who need CPAP and the duration of hospitalization. It was better in the control. However, we have another Egyptian study evaluated inhaled steroid, inhaled bronchodilators, beta-2 agonist, and epinephrine for the treatment of the transient tachypnea. Separate, not combined, and they found no positive outcome. There is no improvement in the baby with transient tachypnea of the newborn who received the inhaled steroid in post-study. Cochrane review, we have 2 Cochrane review, one 2020 and 2022. for the treatment of transient tachypnea, and both of them was unable to find any positive effect of inhaled steroid on the treatment of transient tachypnea of the youth. So what about the meconium aspiration syndrome? Also, we have generations of neonates in Egypt because the high rate of cesarean section. Also, we have lower number of babies with meconium aspiration. So meconium aspiration syndrome, we have the pathogenesis, we know we have mechanical effect, either obstruction, complete or partial obstruction of the airway with consequence of atelectasis or pneumothorax, plus the chemical pneumonitis, which appear. Both of them or all the effect will lead to hypoxia, acidosis, and the hypercapnia, which may lead to pulmonary hypertension. Activation, meconium aspiration was part of the pathogenesis, especially the chemical pneumonitis, the activation of macrophage, reduced intense inflammatory response, infiltration of polymorphonuclear lymphocytes into the lung, increase the vascular permeability, causing protein exudation in the alveolar spaces, and inactivation of the surfactant. So this is why the pathogenesis of meconium aspiration syndrome severity is related to the clinical. Severe inflammation, we have more worsening clinical condition. So suppression of the inflammation looks to be logic in the management. Steroid can downregulate the inflammatory process, and cytokines using a steroid to suppress inflammation in infant with meconium aspiration syndrome could be beneficial. Actually, most of the study came from India. One study came from the United States. Local and systemic administration of steroids resulted in both of animal studies and even in pediatrics decrease histological neonatal age group, decrease histological evidence of pulmonary inflammation, improve oxygenation, decrease neutrophils migration, reduce reactive oxidative damage, and subsequently decrease the pulmonary tissue necrosis. I will review the meta-analysis. This is the latest one. It's reviewing 10 studies, 4 studies for systemic steroid usage in bronchopulmonary dysplasia, and we have 6 studies using either inhaled and or inhaled plus systemic. So we have 2 studies compared nebulized normal saline with IV D10 5 water or no treatment as a control versus IV methylprednisolone or nebulized budesonide. We have 3 groups. 2 studies compared nebulized normal saline versus nebulized budesonide. 1 study compared nebulized 3% sodium chloride with IV normal saline to nebulized budesonide and IV methylprednisolone. 1 study, patient receiving intratracheal instillation of surfactant or intratracheal instillation of surfactant plus budesonide. This is also intratracheal instillation is used for surfactant for management of meconium aspiration. So we have low quality evidence suggests that steroid therapy do not reduce the mortality in case of meconium aspiration syndrome. Very low quality evidence suggests that inhaled budesonide reduce the hospital stay. Both methylprednisolone and inhaled budesonide reduce the duration of oxygen requirement. So take home message. Inhaled steroid might potentially improve the pulmonary inflammation while avoiding any systemic or less systemic adverse effect. The early administration of inhaled steroids seems to be effective in prevention of bronchopulmonary dysplasia, but the serious issue regarding the increased mortality in the treatment. And again, when I review why the mortality rate is high in neuraces, no definite cause found, and some research that said because they receive very high dose of inhaled steroids. They started by 400 every 12 hours, for like 14 days. The earlier, no significant benefits of late inhaled steroid administration for prevention of bronchopulmonary dysplasia. The intratracheal instillation of budesonide and surfactant is a promising option for prevention of bronchopulmonary dysplasia, and we need more trials in different sites, site for it. Inhaled corticosteroid has no role in the treatment of transient tachypnea of the newborn. Inhaled steroid have minimal effect on respiratory distress, oxygenation, and duration of hospitalization, but not in the on the mortality in cases with meconium aspiration syndrome, and still need more randomized trial. Thank you.